Thank you very much for the kind invitation and putting this together. So I think from now on, we move towards the adulthood of high myopia and talk about the complications that we see mainly in the adulthood. I think that already highlights how much we don't know about the progression of myopia from childhood myopia from Lilian's talk through the various pathological changes in the tissues that Kyoko and Jose has talked about. And then now, suddenly we go into adulthood and we face these patients with sight-threatening complication. And of course, myopic CNV is one of the most immediate, sudden sight-threatening complications that can happen to otherwise very healthy working individuals as well. So it is a huge problem. And in my talk, I'm going to discuss diagnosis and management. So there are two published guidelines published a few years ago, which still applies mostly as of today, but I'll try to update a couple of points as well. So in terms of the diagnosis, first is, okay, we have various modalities that can help us diagnose the presence of a CNV. But when we talk about a myopic CNV, one of the key basic fundamentals is to differentiate a myopic CNV from someone who is a myope who has a CNV due to other reasons such as idiopathic, inflammatory, etc. So there are various modalities. Multimodal imaging is always the gold standard and most reliable that can show us the presence of a CNV. So here we can look at the color fundus or fundus examination. We will often see a grayish color, small membrane without some hemorrhage. However, in a myopic fundus, it can be quite difficult to differentiate that sometimes. And so OCT is really by far the most useful screening tool. We'll talk about the specificity and sensitivity in a moment, but this kind of a hyperreflective mound in the outer retina, usually above the RPE, is typical of a myopic CNV. And if we were going to perform an FAICG, these are typically a type 2 CNV that has breached the RPE. Of course, on the right-hand side, we see the OCT angiography, which, if it is available to you nowadays, has become a very quick screening tool. So when we see the abnormality on the OCT, we quickly confirm the flow signal within that mound of tissue on the OCT angiography. And when that is present, we can maybe skip the FA step and be quite confident there is a presence of a CNV. Now, going back to, is it a myopic CNV? There are other features we need to look at. Of course, we expect it to be mostly a type 2 CNV. When it is in close proximity to a lacquer crack, as in this case, it gives us extra confidence. And of course, the fundus, look back at the fundus, look at the peripapillary atrophy, we can see the lacquer crack. So those are the features that suggest that the CNV has developed because of the other pathological changes due to the elongation of the eye. So since that publication just now, many groups have reported the sensitivity and specificity of using OCT angiography compared to FA as a gold standard, and most have reported very high sensitivity and specificity, over 90% easily. And one of the latest down here in eye was a meta-analysis. Again, you can see here the conclusion after looking at 400 studies was that OCTA can reliably diagnose myopic CNV in clinically suspected patients. What does clinically suspected mean? Symptomatology, fundus examination, and again, going back to the structural OCT when we see that hyperreflective mound. However, it says that SDOCT itself may not be reliable establish a positive diagnosis of myopic CNV. What does that mean? It means that it may not be specific. Let's look at some example. That's when we talk about the differential diagnosis. Here we see various examples with hyperreflective material in the outer retina. So when we see that, okay, we first look, there may be a myopic CNV, but then we have to think of other reasons. So some of the common differential diagnoses would be a lacquer crack bleed, such as the top case there, and we will have to continue to evaluate with OCT angiography and ideally FA-ICG to exclude the presence of a CNV there. In the middle example, these are hyperreflective mouse with a very telltale hypertransmission tail, and these are common features in terms of inflammatory granulometer, such as in multifocal choroiditis, PIC, etc. So this is middle example here is a case of PIC. And then there are other examples shown here. And then on the left-hand side is a case when there is actually no CNV, because we don't see any hyperreflective material. We only see the fluid, and in this case, the fluid is secondary to the dome-shaped macula. In terms of treatment now, there has been little change over the past few years from the studies concentrating on Lucentis. These are the Radiance and Brilliance study, and the study on aflibercept on mirror study. So I won't go into the details because they've been around for a long time, but it suffices to say that you can see that really the treatment arm, you can see in the oh, okay, there's a pointer group. So in the ranibizumab arm, and here, as well as the aflibercept arm, these all improve very promptly and continue to maintain that visual acuity. In terms of comparing between one drug to another, seems to be very, very similar. About 70% of eyes gained at least 10 letters in both the Lucentis study and the mirror study. Here we're in euretina. So one key question that often gets asked, as Jorge has mentioned, is there a difference between the Caucasian and East Asians? And within the Radiance study, this particular question was asked, and you can again see that for the Lucentis treated patients in the orange and yellow arm in both Caucasian and East Asians, the behavior was very, very similar. I haven't mentioned the green arm because I think very few of us do that already. That is, at that time, there was a PDT group in comparison, and you can see that the treatment outcome was not very good. And when they were switched over to ranibizumab during the study, they subsequently gained some vision but did not catch up. So the first-line therapy, therefore, is anti-VEGF, as we do now. In terms of number of injections, overall, this is very low. Okay, in the Radiance study, it's about 2 injections over the year. And in terms of patient asking me, what's my chance of getting away with 1 injection? We have that data from the Radiance study. It was about 30%. But nonetheless, you can see if we talk about mean, 50% had 2 or less injection. And that is similar when we're using Eylea, a median of about 2 injections over 48 weeks. What's new? The faricimab is a new thing in neovascular AMD and DME, and it is currently undergoing a clinical trial in myopic CNV. The scientific rationale, however, needs to be discussed. Are we relying on the drug for durability, which is what is being used in terms of neovascular AMD? We know that myopic CNV patients need very few injections anyway, so is the durability going to make a lot of difference? We'll wait and see. Secondly, what is the role of angiopoietin 2? That is a very interesting question, and I don't think we actually have very good data in terms of angiopoietin. The Tie2 pathway is supposed to stabilize the vasculature. Whether that is going to lead to additional advantage in the context of myopic CNV, that will be interesting to look out for. So once we've started treatment, OCT, structural OCT, continues to be the mainstay of monitoring. Here you can see that the hyperreflective material slowly becomes consolidated. It shrinks a little bit, but the telltale sign to know that a CNV is stabilized is the encapsulated appearance. Remember that these are type 2 younger patients with a relatively healthy RPE that has the ability to go and crawl over the lesion and encapsulate it. And in terms of recurrence, here is a great example showing you the difference in the morphology of an inactive lesion on the left and a new active lesion on the right. Note the relatively absence of fluid. So in myopic CNV, we don't look for fluid very much. OCT angiography shows us the presence of a CNV, does not show us whether it's active or not. With treatment, does it show us a shrinkage of the lesion? Does this example show you? Well, actually, this example shows you the same lesion on the same day. I just used a different segmentation. So in terms of quantification of OCTA, it remains to be a challenge and it's very unreliable. Here are some more examples. After treatment in an inactive CNV, you can sometimes see persistence of flow even in an inactive lesion. And when there is atrophy, you may even get an artifact from the underlying choriocapillaris showing through. So with that, I'd like to conclude anti-VEGF is the mainstay of therapy. Very few injections required overall. OCT and OCTA have progressively overtaken FA as the diagnostic tool, but for monitoring, we still rely on OCT structural scans. Thank you very much for your attention.
Thank you, Jemmy. And next we'll be having